All right, we next have Dr. Danielle Andrade from the University of Toronto, and she will be continuing our focus on adults, but focusing on movement and gait issues that emerge.
Thank you. Thanks. I just want to mention something about the transition. With the Dravet Syndrome Foundation, about last year or the year before, we created a transition cheat sheet, which is something for parents to download and so they can download for free. It's on the DSF website. So there's some guidance on what to do and also some information in case you end up in an emergency room where no one ever heard about Dravet syndrome in the adult world. So it's kind of a summary of things that happens to adults. So just something for you to keep in mind. Okay, so I'm going to be talking about movement and gait disruption. You've heard some of that. Here are my disclosures. And gait and movement disorders is just a part. As like you know very well, Dravet is a lot of things. So we do have the epilepsy, we have the autism, the intellectual disability, all the motor problems, gait problems, some digestive issues that we don't talk too much, maybe because we are neurologists and we don't think about them very much, but I'm sure you as parents do know about these problems, as is the case for sleep and the heart. So we'll focus on these two things here. And just as a quick recap, so we keep throwing some words at you. So SCN1A, you know, is the gene. The gene makes the protein. So the gene is actually located. So this is a cell. This red blob in the middle is the nucleus of the cell where you have the DNA. And the DNA is where the SCN1A gene is. And it will make the protein, which is the NAV1.1, which is a sodium channel, which then moves on to the surface of the protein, the plasma, which is the wall of the protein. The protein itself is like a channel, so it's like something round like this where the molecules of sodium will trickle through. And there's this special center area where in one study, we saw that patients that had some type of movement disorder were the ones that had mutations in that area more frequently than in other areas, but this is just one of the things that can contribute to the variability. And then keep in mind, we have the same DNA all over our body, but the cells will switch on and switch off the gene for the SCN1A, for the sodium channel in different parts of the body, right? So we have a high expression in the brain, in the spinal cord, and this is a schematic of the peripheral nerve and the muscle. So, and of course, in the heart. So we have SCN1A cells expressing this gene in several regions, and that might contribute to the reason why we see so many different things in patients with Dravet. Now, back to the movement disorders. Dr. Burkholz explained to you already, but I'll just talk a bit more about this. So one of the first things that we see in patients with Dravet is this neck going forward. And to be honest, initially, I just thought it was my patient's posture, like they were sitting there and kind of not very worried with much. But then when a movement disorder specialist came to my epilepsy clinic, it was so interesting because from the door, he opened the door, he saw the patient sitting there, and he would say, he's an Italian guy, so with his Italian accent, he would say, antecollis. And then the next patient comes and he goes, antecollis. And then the third patient comes and the fourth. And then we end up seeing that it's very, very frequent. Sometimes the anticolis is too much, and you have something like this, which is the chin to the chest. Most of the times, we'll see something like the first and the second picture only. But if you pay attention, we do see a lot of this. The other problem that we saw is that sometimes the patients tend to have this posture where they lean to one side, and for obvious reasons, this was called the Pisa posture, so not very creative neurologists. But again, it's saying that there's something wrong in the brain, perhaps in the peripheral nerves, that makes these problems with the posture. Now, an extreme evolution of this is what we call camptocormia. So this is a patient that has this posture all the time. She really cannot extend and stay more like straightforward. She only extends when she's lying down at night. Then her muscles relax and she can lie down. But otherwise, whenever she is awake, she's bent forward like this. So we know that all these three things that I showed are part of what we call Parkinsonism. The other thing that is also part of the Parkinsonism is the rigidity. And again, this is like the muscle stiffness. And there's two different types. We neurologists like to name everything in detail. So we have the lead pipe and the cogwheel rigidity, but it doesn't matter. Both are significant forms of rigidity, and they affect patients with Dravet more than we expect in patients with other conditions. And finally, the Parkinsonian gait, which is when you walk with small steps. I'll show you a video of that. So there's so the things that I showed you about posture are already Parkinsonian things that we see in terms of posture. And now there's the Parkinsonian gait, which is walking with small steps. When they turn unblock, like as a little robo, several steps to turn around. They have very little arm swing when they walk, and the postural instability, which is the difficulty with balance. So when you put all this together, it's called Parkinsonism. It's not necessarily Parkinson's disease, and this is important because if it were Parkinson's disease, we would be able to try other medications. But it's probably not that. So it's Parkinsonism. We described this 10 years ago now, 2014. And when we saw this, we saw that a few patients did get better with levodopa, but not all of them. In the same realm of things, there's the speech problems. So Dr. Ingrid Schaefer from Australia described speech problems in patients with Dravet, which are, again, typical of patients with Parkinsonism. And more recently, actually this year, there was a study on a few patients showing the effects of levodopa. And similar to what we did in 2014, they also saw benefits in a few patients, but not in all patients. This is a study summarizing the gait abnormalities, but this study was published in 2019. We have one more after that. But anyways, it shows ataxia, which is something I didn't talk yet, but I will show you a video soon. The crouch gait, which the Australian group and we published in 2012, and then a few other problems with gait as well. So it's not just one thing. So here's kind of the evolution. Ataxia is something that Dr. Dravet described with Dravet syndrome back in the day. And it's interesting because it's not very prominent in adults. It happens, but the kids seem to get better from the ataxia. Ataxia is like when you're walking as if you were drunk. You can't really walk in a straight line. You walk with your feet a bit apart, and that is a problem with balance. Then the crouch gait, described by Rhoda and I at the same time. Then the Parkinsonism, the comparison with Lennox-Gastaut. Dr. Burkle already mentioned that. And then we follow some patients that we studied in 2014 2014, and we saw them again in 2019, and I will show you soon the results of that. And it showed that there was a progression, so meaning things tend to get worse with time. So over a 5-year span, we saw several things that actually got worse, unfortunately. And the study, the Japanese study, that confirmed the response to levodopa. So here's a video with a patient that has ataxia. She has other problems as well, but you can see that as she walks, her feet are separate, and she can't go on a straight line. She kind of weaves side to side. So that is ataxia. Then we have the crouch gait. So the crouch gait you've seen, this is me trying to ice skate. When I put an ice skates on, I will flex my hips, flex my knees, keep my feet apart, because that will lower my center of mass and will help me stay and not fall to the ground. So that's basically what patients with Dravet that have crouch gait are doing. They are lowering their center of mass so they won't fall down. And this is, oops, let me show. So you can see that as they walk, they do not extend. And then the classic Parkinsonian gait. You see this patient, very small steps, very short steps. She doesn't swing her arms. Her posture is stooped forward. Her head is leaning forward. And she has difficulty to turn around. She will turn around and block and all that. So here are some studies showing that levodopa seems to help. And when we look at our population and we follow them over 5 years, we saw same thing, and I'll show you in the next slide. So these are the patients some of them we saw in 2014, and then we saw them again in 2019. And this is hard to read, but I'll show you. We looked at the resting tremor, the facial expression, the ability to get off a chair, stand up from a chair, and their walk. So what we saw, and here's the patient number, and their age in 2014, their age in 2019. And then the second patient, their age, their age, and their age. And here's the total score. The higher the number, the worse the movement abnormality. And what we saw is that 4 out of the 5 patients we followed got worse with time. This one didn't. This was a younger patient, and we started her on levodopa when we saw her in 2014. We can't tell for sure that that's what happened, but now with this last Japanese study that was published today, it seems like it might really have been some contribution from the levodopa. And then we have this patient and this other one here who were ambulatory, so they were still walking with a lot of difficulty, but still walking in 2014. When we saw them again in 2019, they could no longer walk, so they were on a wheelchair. Then we look at other patients that we have not seen in 2014, but we look at all those things, and again, we could tell that older patients had worse symptoms, both in terms of their gait or their movements. Everything seemed to be worse in those older patients. One of the studies we did is what we call the instrumental gait analysis, and this is what we were doing in 2019. So the patient has to walk. This is a gait that has sensors, so we can feel the step, and there's a lot of cameras on the patient as well. And as I mentioned, we finished this in 2019, but then we wanted to get the control population, right? Because every time we do a study in patients, we want to have the controls. And usually want to have age-matched controls. But then it was 2020, and with the pandemic, we really couldn't bring anyone to the lab. So what we did, we look at what we call historical controls, patients that had been controls for studies that were done for something else in the past, but we knew they didn't have any gait problems, so they were controls. And the patients with Dravet were worse than the controls in all aspects of their gait. The problem is that those patients that were the controls were 62 years old on average, and our patients were just 31. So they were doing, the Dravets were doing worse than patients that were double their age. So then we wanted to know, why is that? Is there anything to do with perhaps the medications they took in the past? So we decided to expand this and look outside of Toronto to more patients. And I know some of you that are here today participated in this study, so thank you very much. DSF was amazing helping us talk about this study and recruiting patients, adult patients. So if you are one of those families, thank you very, very much. So we started, what we did, we started recruiting patients remotely, and we validated our tests so it could be done from a distance. So here's what we got. We have 92 patients. We have patients from Canada, from the US, Brazil, Spain, United Kingdom, France, Australia, and one patient from Cyprus whose mother I met yesterday here, so it was fantastic. The mean age of this group was 27 years old, and the average age of diagnosis was 16. So this is important. So as you heard this morning, many patients had their diagnosis after the first prolonged seizures nowadays, or at the age of 2 or at the age of 4. The patients that we saw, these adults, 27 and something, they went on average 16 years, sometimes more, sometimes 20-something years without a diagnosis, which means they were exposed to medications that today we know we should not give to these patients on a routine basis. We asked parents if they notice any change, specifically if they notice any decline in the patient's ability to function. And here's the response. So when we asked, did you notice any change in intelligence over the last 5 years? Like if you look at your loved one now and compare to what it was 5 years ago, and this is very, it's not precise, it's just an impression. But we wanted to get this impression because this is what I hear in the office every week, parents coming and say, doctor, she's no longer able to do this, which she was doing before. He's no longer to do that, which he would do before. So I wanted to know if this was something we were seeing in Toronto only, or it was more widespread. So again, take it with the grain of salt. It is very subjective, but we wanted to hear the parents' impression. And 15% of parents felt that there was a decline in intelligence, 23% in the speech, 44.9, so 45% in gait, 23% in the ability to walk without any support, 31% ability to climb stairs, 20% hand coordination, and 15% in the interaction with others. So this was just the basis so we could explore a bit more each one of these things. As I mentioned, this older population took much longer to get the proper diagnosis, so they were exposed to CIM, contraindicated medications, for a much longer period of time. So 81% of them were exposed on average 5 to 13, 15 years sometimes. What did we see with regards to the Parkinsonian manifestations? So first of all, how did we assess that? We created a video and with a tutorial to ask parents to record these things with their own smartphone. And then when we got these responses, out of the 65 videos, 5 had to be excluded for technical reasons, but we had 60. And out of the 60, we saw Parkinsonian manifestations in 98% of them. You're going to say, well, yeah, this is bias. Parents that felt that there was something with the movements were the ones that sent the video. Still, if you think about that, it's 60 out of 92, so 2/3 of patients felt that there was something wrong in terms of movements. what did we see was that the symptoms, and we used a scale to classify this. It's called the Modified UPDRS, Unified Parkinson's Disease Rating Scale. So the UPDRS is standard to classify Parkinson's disease anywhere in the world. We modified it for Dravet, and we validated this 10 years ago. So we used the same scale. And we saw that the scores were higher, meaning patients were worse, and the old ones were worse than the younger ones. And that was statistically significant. And the other thing that we saw was that those patients that were exposed to phenytoin seemed to be even worse than the other patients. We didn't see that so much for the other ones. For the Parkinsonian, we did see for phenytoin, carbamazepine, and lamotrigine. That was significant. For the Gait was a bit different. So for the Gait, what we did, we used similar tutorial video, and then we used some pose trackers, and this is like a very fancy thing that the movement disorder Gait specialized people worked on this, where they would extract, look at the video and use these algorithms to make sure they knew which joint was moving, at what speed, and how the joints were aligned and aligned with the body, and a bunch of other things. Very complicated, but it is validated. It is something that can be used to evaluate Gait from a distance. You don't have to bring the patient to the Gait lab. And that was very important for us because with a rare disease like Dravet, you can't bring everybody to Toronto. And then we also asked about, it's a simpler scale that the parents can answer about how far the patient can walk without support, and if the support is just holding hands, or if they need crutches, or if they need wheelchair, and this and that. So when we boiled all this together, again, the Gait was worse in the older patients, and in terms of, and here are the specific things that were worse in those patients, and it was independently of the age, those patients exposed longer to contraindicated medications were doing worse, and phenytoin appeared to be the worst of the sodium channel blockers for Gait specifically. Perhaps if we had a larger sample, we would see that with the other drugs, perhaps not, we don't know. But with this sample that we had, phenytoin seemed to be the worst one. Now, this is for phenytoin every day. It's not, we're not talking about the patient that is in status epilepticus, goes to the hospital and needs that. That's a different story. We're talking about patients that take phenytoin day in, day out for years. We also look at adaptive skills, and again, it was worse in the older patients. Remember this morning, Dr. Birol talked about autism and how it might be underreported. So we used something called social communication questionnaire, which is not the official test to say someone has autism, but it's something that we use to screen patients that are at high risk for autism. And 77% of patients were at high risk. So these are patients that probably needed to be further tested to really confirm if they have or not. And we didn't see any impact of contraindicated medications on those patients, at least not in the population. We said like it's 90-something patients. Maybe it's different if we study more, but likely medications are not involved in the autism risk. So to conclude, the motor problems that we see they are very important and very widespread in patients. The Parkinsonian features, they include the gait, the speech, the tone, as well as the balance. Some of those can improve with levodopa, and probably it's better to start sooner than later. So as we saw, and the Japanese study also showed, patients that started earlier had a better response. The Vineland's tree, and this is probably not so important unless you are doing a clinical trial, but what we saw is that the Vineland's does not capture the motor changes that we saw with the actual video, so it's much better to see things. You will not capture those things just asking questions. We confirmed that the homemade videos are a good way to evaluate gait and Parkinsonian features, that they were worse in patients that were older, exposed to the wrong medication. And then what are the next steps? So the next thing that we want to do is try to understand better. As I mentioned, the protein is expressed in the brain, the peripheral nerves, and the muscle. So why these patients have Parkinsonism, why they have this or that. So we know that SCN1A is responsible for a lot of things, but even then, some patients are better than others. And we want to understand to what extent the genetic mutation is responsible for the things we see. So, you know, we always talk about genetic tendencies. So in my case, for example, I have a genetic tendency to have high blood pressure because it runs in my family, both sides of my family. Now, there are things that we didn't know we could actually measure genetic tendencies until recently. And those might be relevant for patients with Dravet. The way we look at them now is different. So you have your gene causing Dravet syndrome, SCN1A, but you might also have a genetic tendency for high blood pressure, for diabetes, for heart disease, heart arrhythmia, for autism, for intellectual disability. And this is what we want to measure going forward. So this is called polygenic risk scores, the way of measuring this genetic tendency. And we are starting to look at this, starting in the patients that were part of this study that I just showed you, the 92 patients that were part of that, but we are expanding that. And as I mentioned, for patients with Dravet, we are specifically interested in understanding their polygenic risk score for autism, for intellectual disability, for heart arrhythmias, and Parkinsonian manifestations. So if you are here and your adult child is here, we are actually doing 24 hours Holter monitoring. And if you are interested in participating in the study, we invite you to come and talk to us. We would be doing, this is a wireless Holter, so there's nothing to, like there's the patch here, but it's wireless. And we would collect saliva sample to get the DNA as well. Here is the QR code, so you can look at the study, the consent, and if you have interest, please come and talk to us. We will be doing this. We started already. We already have some patients that are hooked up. And I will stop here and thank a lot of people that were involved in this study, looking at so many patients, and take any questions if you have.
I just have a quick question. So besides the medication, are there other therapies, like physical therapy, or other things we can do to help prevent some of these gait problems?
That's an excellent question. So we know that anyone will start losing muscle mass as they reach a certain age, and physiotherapy will help with, exercise and physiotherapy will help with that. So the sooner you start, the better it is. As I mentioned, levodopa might be something that, and again, there are so many different things happening at the same time in patients. So some of them, they might have more Parkinsonian features, others might not have so many. So your provider would have to evaluate to see if levodopa would be appropriate. But certainly physiotherapy and physical activity would be very important.